and you're all very welcome to the Health and Wellbeing Board of Wednesday, the 15th of June 2022. There's a first couple of items which are just to be noted, and item number 1 is the appointment of Councillor Dr. John Doddy as Chairman for 2022-2023, which was done at our last council meeting. Item number 2 is the election of Vice Chair, which will be postponed probably for a couple of meetings till the statutory position of various boards are established, and none of which are established at this particular moment in time. And for that, we are grateful for Jeremy to indulge us with his presence going forward. Terms of reference. I've got something here about terms of reference, and I've got Marjorie Toward. Has Marjorie actually turned up in order to tell us anything about this, or is it just for us to consume?
It's just a note, Chair, in the same way as just a note the election of you as Chair.
The terms of reference haven't really changed, just the same statutory requirements that we've had since we were established following the Health and Social Care Act 2012, introduced by Andrew Lansley, requiring us to do a health and wellbeing strategy, which is fantastic because we've just launched it this week, to also present joint strategic needs assessments, which is fantastic because we're talking about that exactly this afternoon. So if there's anything on the terms of reference, by all means let me know, but they are just for reference. I'm going to move on to item 4, which is the minutes of the last meeting, and I'm just going to count the pages through. Page 1, 2, 3, 4, 5, 6. Hang on, I've got to page 6 and I've got an interruption.
Yeah, there's a correction there, please, Chair, from which I've already spoken to. But so around the undertaking of work around a voluntary sector alliance, it's not Healthwatch that's undertaking that; it's the voluntary sector infrastructure. So we've agreed that.
We made an adjustment.
Yep. I'll have a word with Sue after the meeting, Sarah after the meeting, make sure that I get the wording right for that section. Thank you.
Thank you, Sarah. Page 7. Just for noting, what page was that on, Sarah? Page 6. Which paragraph? 1, 2, 3, 4. Second to last. Sarah Collis. Okay. 7 and 8. So they are the minutes. Can we have those approved? All those in favour? Yeah. Approval of the minutes. Now, I'm going to have a little look here, and I've got some apologies for absence. Pete, would you like to update us on that?
Thank you, Chair. We've had apologies from David Ainsworth and Idris Griffiths, and Councillor Creamer's replacing Councillor Place. Sue Batty is replacing Melanie Brooks. Dawn Jenkin is replacing Jonathan Gribbin, and Stuart Newman is replacing Fiona Callahan, all for this meeting only. Thank you.
Thank you, Pete. In terms of the agenda, we'll move on to item number 6, which is a declaration of interest by members and officers. If you have any pecuniary interest or private pecuniary or non-pecuniary interest, now is a reasonable time to declare them. However, if anything crops up through the afternoon and you remember something, I'm more than happy for you to interrupt and tell us at that time. Thank you. We're going to move on to item 7 now, which is the Chair's report. So the Chair's report, if we have a look at it, has a number of topical items which we try and tie in with the health and wellbeing strategy, the integrated care partnership, the integrated care board, and try and make them relevant to Nottinghamshire. Many of you who are here for the first time on the board, and Pete, did we introduce the people who had just... I'm going to break off and go back because we have had some significant changes to the board. And Pete, did you want to make that... Go ahead.
Yep. Thank you, Chair. So, yep, we'd just like to welcome as a number of new appointments to the board. And again, these are just a note. So can we extend a warm welcome to Councillor Scott Carlton, Councillor Sinead Anderson, Councillor John Wilmot, and Councillor Tim Wilgust. Welcome. Thank you, Chair.
Thank you, Pete. So the Chair's report had historically got as many as 100 items on it. We've shown great restraint today, and it's down to 25 relevant items, which is quite good. In terms of just looking through it, if anybody has anything that caught their eye, I'm more than happy for you to bring it up and we'll talk about it. Item number 6 caught my eye with regard to travel, etc. There is a big drive towards activity, towards being active, towards cycling, and Stapleford, where I am, got awarded £79,000 to do some work around whether or not a Dutch-style cycling system would be of benefit to those people. So this is money for a consultation. The actual introduction and creation of these things costs millions. So, but we've got 79,000 in Stapleford, and we'll be getting together and examining whether or not the mini Holland system would be useful. It's a programme of funding to try and transform places into cycling hubs. There's high specification around the infrastructure which provides safety for people on bicycles when they're cycling, safety for people walking, safety particularly at junctions. And we'll have all been familiar with the pictures of the roundabouts which have a cycling lane around the outside, but if you've got 4 junctions coming down, each junction actually has a zebra crossing at each of the junctions, making traffic automatically slow down on approach and equally well slow down before they exit it. So it's all about safety and encouraging people, but equally well by reducing motorised transport towards walking and cycling. It's also part of tackling the cycle or the climate emergency. So I'm particularly keen on that. I'm particularly keen on it because Stapleford is my area. We'll see the increased money being spent on drugs and alcohol, which we dealt with at the last meeting. It's particularly nice to see in item number 18 that we have significant monies being invested into schools in order that those schools are able to create mental health leads, because we're seeing the huge toll that COVID over the last 2 years has taken on youth and the mental health of our young people. So that's £7 million to make sure every single school has a mental health lead, and the importance of that cannot be overstated. I was particularly interested in item number 21. And it talks about multi-buys and high fat and sugar and salt and all that sort of stuff. But the only thing that actually came in on the 6th of April was the requirement for calories to be labelled on food, etc. So if you go to your McDonald's or you go to your Kentucky Fried Chicken or a restaurant, you'll see exactly how many calories there are in those particular foods. And I think that's a very important thing for us. It's companies that employ more than 250 people. So these are, you know, medium-sized to large-sized companies. So you won't typically find this on your small restaurant or tea shop, but it will be on the bigger organisations. And equally wise, certain places such as hospitals and some care organisations and nursing homes, etc., have not been required to do this, so you won't see calories on those either. The impact of calorie labelling will be quite interesting to follow over the next number of years, and hopefully in the near future the sugar and salt restrictions will follow, but for now they're not part of the package. So that's calorie labelling coming to a restaurant where you eat soon. Susan.
Thank you, Chair. I've got a couple of just a typo on number 3. It said one youth project is in Bassetlaw. I'm disappointed that it's not in Bassetlaw because it's in Mansfield. So there's just a typo on number 3. And I was interested that in your comments just now about the conclusion about the changes in the new legislation. I was disappointed that the government didn't include what was going to be in there about advertising before 9 o'clock of fatty foods and highly calorific to children on TV. And the other thing that went out of that legislation was the buy one, get one free of high fats and sugars in supermarkets. So for the good things that it does bring, there were a couple that it was just disappointed that they came out of the legislation.
And we can never underestimate the ability of the food industry to circumvent the challenges that are thrown before it. I do remember, I think it was last year, the year before, that they put the sugar tax on, and I went in to buy a Coke, and the price of it had gone up because they had to pay sugar tax on that compared with the diet one, but they were actually doing a buy one, get one free, so they actually managed to bring down the price of it rather than increase it. So there's a great deal of ingenuity out there that we have to sort of overcome as well, Susan, but I fully support exactly what you said, and we need more measures, and we need them now, not next year and the year after. Obesity is part of this as well. That's in item number 25, talking about obesity and overweightness, when 70% of the population are overweight or obese, which is quite huge. I'm drawn towards item number 27, and I'm going to stop after item number 27 and take anybody else's opinions with regards to it. It's an item on tobacco. And I'm going to particularly tie that in with something that you're all aware of recently, which was a chap called Javed Khan recently published a paper on requiring Nottinghamshire to become smoke-free by 2030. I think it's wonderfully ambitious and something which everybody involved in health and wellbeing, the integrated care system, right down to health inequalities on the Integrated Care Board, will be delighted to see smoke-free Nottinghamshire. That doesn't mean that nobody will smoke, it just means that less than 5% of the population will actually smoke. And people say, is that an over-ambitious thing to require of the people of Nottinghamshire? And you have to be aware that at the present moment there are areas that are smoke-free. So if you look at places like Ashfield and Mansfield, you may have smoking rates of 19-20%, but Rushcliffe has smoking rates just over 5%. So part of it could already be declared a smoke-free area. The government is going to plough £125 million into smoking. It's going to particularly ring-fence 70 million of that towards stop smoking services. It's been well known that people who attend stop smoking services, in the past it was New Leaf. Many of you may remember New Leaf, and currently it's ABL, A Better Life, providing it through Your Way, Your Health. So 3 times as many people will stop smoking if they attend a stop smoking supervising session, and therefore these are very important. There was also talk about increasing the age at which you could buy cigarettes by 1 year every year from the age of 18. So you can imagine that in 5 years' time it would be 23 before you'd be able to buy a cigarette, and this was piloted first in New Zealand, and it's something that we're following on from there, but remarkably important. The other big thing that's going to come through is the availability of vaping and the promoting of vaping. 95% at least safer than it is to smoke. Nicotine itself is non-carcinogenic compared with the fact that smoking contains tars that cause at least 30 different types of cancer, and is still the biggest killer of pre-70-year-olds in the country. Over 1,000 people in Nottinghamshire every year die as a result of it. It causes chronic lung disease, heart disease, angina, strokes, as well as lung cancer, which 40,000 people die per year. Smoking is the #1 cause of health inequalities in the whole of Nottinghamshire. I'm proud to say Nottinghamshire's health and wellbeing strategy has it as one of its 9 priorities for the next 4 years going forward, and 50% of the age gap between people in the best areas and people in the worst areas is entirely down to smoking. So I think 70,000 deaths a year, 40,000 of them lung cancer, and the biggest cause of premature illness and premature death that exists. Makes absolute sense that we concentrate on this, absolute sense that we aim for a smoke-free society by 2030. And it's absolutely, entirely achievable. That's the other beautiful thing about it. I'm going to stop on the Chair's report at that point in time, and I'm happy to take any questions, should there be any. Councillor Wilmot.
Thank you, Chairman. Can I first of all congratulate you on the comprehensive report that you've put forward, and you've not put anything in that's, what shall we say, that you shouldn't have done. In respect, every item on it seems to be appropriate. Yeah. Well, welcoming the new website, you must remember that a percentage of the population don't have the web. So I do hope you take that into consideration when you're doing reports, and make sure that somehow we do contact many of these people that don't have a website, and which includes a lot of the elderly, yes. which is it's very important that they get to know all the issues. As far as giving every child the best chance of maximising their potential, obviously I welcome any youth project, whether it be in Mansfield or anywhere else. Because we all know that every intervention at the present time are the answer to young people's problems, or intervention schemes. But it must start at an earlier age. A child's education starts in the home, and education of the parents on parenting is of prime importance. I don't know whether anybody saw it this morning on television, on radio, etc., that only this morning it was announced that children are starting school not knowing their own name, coming to school with nappies on, and of course basically coming to school without any knowledge of basic skills. So that has to start even before they start learning the 3 R's or anything else, which is not good news. And of course, that is why children's centres are so important, I feel, and that they help with discipline, physical and mental well-being, introduce skills, and create more positive activities to turn the children off crime and antisocial behaviour. And then we come to education. Much more needs to be done in schools when our youngsters reach 13 plus, and giving them more opportunities to learn about trades and learn about jobs that they are interested in, so that they have a start in life. Chairman, in your report, there are many other projects in the pipeline, others that really interest me. Cost-effective travelling, walking and cycling projects that would certainly tackle obesity, but at present, nowhere near enough money is going into that area. That would save lives. Extra face-to-face surgery appointments is welcome, but it is only in one area. And many surgeries, some people are still waiting weeks for an appointment. Hopefully, this will be addressed soon. Moving on, Chairman, the drug taking and other substance misuse is still high on the agenda in most people's eyes, and much more needs to be done in that area. It's good to see the improvement in crime rate in one area. I hope they share that project with other districts and the police chiefs in all areas to see if we are all missing out on any helpful projects. We are all concerned about families going without food, and the government need to address this serious issue. More money must be provided by the government to tackle the cost of living crisis. After all, it is not the population's fault. I see nothing about old age and pension as yet. In some cases, they've been hit the hardest. The county used to have regular aged forums. I used to support them many years ago. I do not see them now, and yet the problem in that area includes loneliness, scam victims, poor mobility, and of course, cost of living crisis, which causes problems with heating their homes and feeding themselves. Well, thank you for listening to me, Chairman. I will look forward to this council improving all the health and well-being of its residents. Thank you.
Thank you, Councillor Wilmot. It was almost like listening to myself. If you look at the minutes of the last meeting, I started off with the chair talks about the problems the teachers are facing with having to deal with pupils turning up at school, lacking the basic skills. And we went on to deal with the phenomenal challenge that is drugs and alcohol, with 170,000 of the population potentially benefiting from alcohol intervention services. We dealt in depth at the last Health and Wellbeing meeting around drugs and alcohol, etc. And you'll find that there's a pattern of reproduction where we come to issues and we go back over them and we go back over them again, and they never become less relevant, which is why I make no excuse for bringing up drugs, alcohol, obesity and smoking at every single opportunity, making every contact count. So there's no need for anything other than to continue exactly what you do, Councillor Wilmot, because it's going to echo what I do and what most of the people here do. Thank you very much indeed. Jeremy.
So, just listening to this, I think, and looking at the changes that are coming ahead in the infrastructures of which the Health and Wellbeing will be a part of, the Health and Wellbeing Board will be a part of, I think it's absolutely critical that we take more of an anthropological view about what is actually happening with our individual patients and public. It's important that we know the bird's eye view, that we know the data, that we know the facts. But it's also critical that we know the worm's eye view as well, so that we actually understand what are the issues that underpin why people cannot make behavioural changes that actually will help their health. What are the systematic things that will actually enable them to do that? And I think that's why it's so vital that you as councillors have got the opportunity to bring those stories. But I think it's important that we actually see on depth to the analysis of those individual stories as well, because unless we actually address the individual factors that stop people making those sort of lifestyle changes, you know, why is a child coming to school in a nappy? What is the story there? Because unless you actually start to address that, the something must be done doesn't actually happen. And I think we do have a real opportunity now to make an intervention on a population by bringing closer those three parts of the triangle: the civic part, the community part, and our services part, to actually start making significant impact on what we're actually trying to achieve.
Thank you, Jeremy. I think it comes back to the fact that if we put out information to a population of 55 million people, we know that it will have an impact on a certain percentage of those people to do or not to do a certain activity. Then you're often left with those difficult to reach groups, and therefore you have two approaches. One is universalism, where you put information out to the whole population, Secondly, you have a selective approach where you look at the population, like people who smoke in Ashfield in pregnancy being twice the national average, and you say, how do we reach this specific group so that we can help them? And I think the mode going forward is going to be a combination of universalism, which works hugely on numbers, but that selective approach, particularly around inequalities, to bring about some levelling up in the health of those least well off. And I think it's exactly what you said, Jeremy, knowing what the triggers are in order to do that. And I think that's absolutely crucial. Councillor Creamer.
Yeah, thank you, Chair. Again, congratulations. And I thought it was fairly comprehensive, and then you said it was only a quarter of what it was before. So thanks for that. It's just a couple of questions and a comment. Going right back to the beginning of the one-year project in item 3, and it finished June 2022. That's now. And I'm just wondering what's happening after it. Will there be feedback? Will the participants be monitored further on, or is it literally just going to stop? The Clean Air Day on June the 16th, was it monitored? Did we get any information back in the future on that, or is it just, it's happened, it's a day? And in general, which you did mention in your verbal, when you're actually doing the national statistics and breaking them down, Rushcliffe is this, Mansfield is that, quite a few of these have got the national statistics in. If possible, it would be useful, if we have got them, to put the Nottinghamshire, so we would actually know what's happening between, say, Gedling and Mansfield or Bassetlaw, etc., etc. And just a very, very general question, when you're on about the traffic and the actual safety and bikes, which I totally agree with, by the way, is there any element or observation of what's happening with the e-scooters at the moment? Because I can actually see people who should be biking or walking, which would benefit them, now using e-scooters. So I'm wondering what impact that may be having on people's health at the moment. I'm not on about the accidents and this, that and the other. I'm about the actual people who use them and reasons for using them. So very general, that one. Thank you, Chair.
Yes, sorry, in regard to the joint health and wellbeing strategy, it's useful that item number 10 talks about the monitoring and evaluation, which will form part of item number 2, whether that be a system monitoring with regards to how the system is going itself, whether it be a place-based monitoring with regard to what's happening in the communities, whether it be a priority monitoring around smoking, around obesity, and the 9 particular priorities that we've laid out. Somewhere in there between strategy, overview and actual following up of individual priorities will continue to the whole thing. The system evaluation will be a yearly one. The place will probably be twice a year, 6 monthly, and the priorities will maybe even be as much as quarterly, and they'll be fed back through public health outcome frameworks and the website itself to be a dynamic illustration of what we're trying to achieve. And it's like everything else, if we find it's not working, we'll stop and we'll review it, and then we'll find something that does work. So it's absolutely that is the case. E-scooters, I have to agree, although it does seem to be an awful lot of young people that are on e-scooters whizzing around the place. They look like they've got an enormous amount of energy. Again, I only see them in the city as such, because that's the only place they're licensed to be. So I have no understanding that the county have any plans done to bring in e-scooters or anything like that. So I can't say much about that. I would entirely agree that the statistics around our locality, produced by our joint strategic needs assessments, looking at the population of Nottingham, are crucial, but not only Nottinghamshire, but Nottingham itself looks like it's, and I'll use smoking again, that it's nationally equivalent to the rest of the country. If you look at England in general, the rate of smoking is something like 13.9%. If you look at Nottingham, it's 14%. So we look like we're on average but if you look at the worst places, they're up to 20+%. The variation across Nottinghamshire in general is extraordinary, and therefore for Nottingham that itself is not good enough. We need the demographics to be going down into each borough and each place, and that's the whole ethos of the primary care networks, the ethos of place-based partnerships, that we correct things in the place that they exist and don't just see Nottingham as a single statistic, because it's an illusion. So I agree 100% with you there, Councillor Creamer. Dylan.
Thank you very much, Chair. Can I draw the board's attention to action point number 18, which I think I really welcome, the increased mental health support for children and young people. My question to us collectively as a board is, can we influence how this funding is utilized? And the reason for my question is, I'm a bit anxious when it says this, within Nottinghamshire, schools are being encouraged to apply for this training as part of the whole school approaches to mental health and so on and so forth. The reason I'm asking that question is because do we understand the needs of different areas and try to address support based on need, as opposed to having a sort of a uniform saying each school have a mental support? Because when you look at COVID data, there are certain areas which have been far more disproportionately affected than parts of the county. So do we have a mechanism of identifying that and then ensuring that the funding follows the needs? Because if there's an equality of service provision, it actually worsens health inequalities, because it's that old picture about, 3 people of different height trying to look over a fence to see how the football match is going on. But if you give the same height stool, the shortest will never see over that fence.
Yes.
The tallest probably doesn't need that stool.
Yes.
And using that same principle across other areas, do we do that? So it's just, I really welcome that. But, and final point is that in Mid-North as a locality, we are doing a population health management place development program. And the cohort of individuals we are looking at is impact of COVID-19 in children and young people. And the data is striking. So it's not similar across the whole of Mid-North. Yep. There are neighborhoods and pockets who are far more disproportionately affected. And then our resources should follow that needs, as opposed to having what we usually have is a bit of a blanket approach and trying to do. So just understanding whether how we as a board can influence this national strategy and likewise in the future.
Yeah, I think it's a classic observation, and it's one in which we come back to time and time again as an ICS board, and those of us who sit on the ICS Health Inequality Board have seen that slide that you talk about. So many times it crops up in our dreams at night time, how to deal with inequities, which are man-made inequalities that we can correct, as opposed to things that are genetic or inherent in our constitution, to which we have no control over. So we have a great duty to do that, and the whole of the ICS board is statutorily obliged to deal with health inequalities. This is not just something that we're being asked to observe, being asked to recognise, being asked to have statistics for, but we've been actually charged as a statutory duty to correct health inequalities, and that can be from mental health. One of the big areas is regards to prioritising certain underprivileged groups with regards to accessing hospital care and appointments, people who are carers, people who depend on carers, etc. So the whole ethos from day one that I'm aware of is tackling health inequalities. Be under no illusion that will not disappear over the next 4 years of health and wellbeing strategy, but is front and foremost and fully understood by all of those people that are engaged in it. Dawn, did you want to add anything to that from public health point of view?
Thank you, Chair. I need to say I couldn't agree more. It's been a long time coming, this focus on understanding that resource needs to go to the areas that face the biggest inequalities and biggest challenges. I think we definitely as a board and as a region can get more sophisticated at understanding and identifying where those inequalities exist. And as Jeremy referenced earlier, understanding what underlies those inequalities. So some of the fantastic work we've done at community level that the board has heard about, for example, in Bellamy, where we actually get underneath those inequalities and understand the real issues and challenges, and therefore how to better address them. I think in terms of your question to the board of how can we ensure that this money is targeted, I note that this is going to be schools who are applying for this money around the mental health support. And what we often see is that areas that are more affluent and less deprived have an easier route or have more voice in applying for that sort of funding. So I think between us, with our influence, we can be really encouraging those schools in the areas where we think this is going, where we know the need is greatest, really encouraging those schools and the schools that you know in your areas to go for this funding, and looking at how we can support them collectively as a board to do that, I think would have a big impact. Otherwise, we know some will be more able than others to put their hands up for this. I'd also just note that the scheme we do have in place, which is the mental health support teams, that will definitely be targeted at the areas that have the greatest need. Thank you.
Thank you, Dawn. Councillor Wheeler, did I see your hand up at one stage?
Thank you, Chair. Yeah, I just wanted to comment on the increased mental health support for children and young people, particularly a bit about schools. On the item 19, it says, within Nottinghamshire schools are being encouraged to apply for this training. The biggest problem we have with the education sector at this moment is that the education system is fragmented, dislocated, and run by a franchise of trusts, these big multi-academy trusts, and it's down to those trusts themselves to decide as to whether they apply for that funding or not. Some trusts are better than others, some academies are better than others, but there's no guarantee that all schools, depending on their ethos and where they are going to apply for that funding, and that, I think, is going to be a stumbling block moving forward. Thank you.
Thank you, Councillor Wheeler. It's almost as though you deliberately have to skew funding. I know when we commissioned ABL to provide services on weight and smoking and activity and alcohol, etc., we skewed 60% of the funding to be used on the 40% most vulnerable areas of society. So that was a proactive intervention into tackling that exact thing that you're talking about. But sometimes tendering and applying depends on the sophistication, and sometimes the most vulnerable are often the least sophisticated, and it creates a cycle in itself. So I think that is, as you quite rightly say, Councillor Wheeler, something which that everybody needs to be vigilant about and positively skew to those areas that we know, as Tillum talks out, have the greatest needs. I'm going to go to the Police and Crime Commissioner and Representative Sharon.
Hi, thanks, Chair. Just to comment, if I may, on the behavioural change that you spoke about. It strikes me that I'm thinking particularly around the drug and alcohol, which I know is quite close to your heart, and often referenced in these meetings. And the need for a communication strategy that really nails the issue. The Commissioner and myself attended a national seminar on From Harm to Hope, so the National Drug Strategy. And there was, there was a wealth of useful information, presentations delivered throughout the day. I think one of the disappointing things we saw was an analysis of public health communication campaigns that had been delivered over the past 20 years or so things like Talk to Frank, etc. And it was pointed out that really the net effect of a lot of those had been that they hadn't really gripped, and quite often in terms of that behavioural change, there were still cohorts within communities and so on who were just disassociating themselves with the impact of what the message was trying to convey and the group it was trying to convey it to. I'm not quite sure how we solved that because, as I say, it was disappointing. It pointed out a lot of the things that hadn't been achieved and didn't really tell us what was a successful communication strategy, but it strikes me that it's something that we need to think about here as well.
Exactly. Thank you very much, Sharon. That, again, it comes down to how you achieve the goal that you set out to achieve. And again, I'll come back particularly to tobacco and say we wanted to stop people smoking. The single biggest worldwide success in every country has been taxation. The single biggest factor that reduced the most number of people throughout the whole of the world is pricing. Now, that pricing didn't affect everybody equally. It affected youth most, as they are most affected by lack of money. It affected, interestingly, women tended to stop more because of an increase in price, and it affected certain affluent retired people who had plenty of money not at all. And therefore you have to skew your interventions to the population that you're going at. So I think that that's one of the most important things. But there are 20 points of intervention that we'll be using in smoking. And alcohol will be the same. So that can be a ban on advertising, that can be making the product less attractive, that can be education going into schools, that can be licensing for people who are actually able to distribute, that can be a host of things, and there are 20 of them in the list of interventions. And I think that that's what you're really saying, that the interventions currently are not as effective as they ought to be, but there are interventions which will be hugely effective. I just saw today that they were talking about tagging people with an alcohol sensor, that they'd be able to pick up those people who are released from prison and those who are abusing alcohol and use that as part of the strategy, which I thought was really, really good. And then they even said that they might be able to find a way in which you could also monitor some illegal drug use. So there are creative minds out there, Sharon. There certainly are. Susan.
Thank you, Chair. Just a couple of comments back about how we deal with the publicity and the comms. Youth workers are really inept at asking young people their views and looking at strategies, and communication and participation with adults, young people. It's about asking them what would hook them to work and reduce their alcohol and smoking consumption. And I think linked to that is the problem we've got where we assume that everyone could stop if we put the taxes up high enough. Mental health is massive, and for some of these individuals that are smoking, in utter trauma through their lives, the only thing they can go to is to have a cigarette. And it seems to the people that don't smoke the most weird thing, because they may not have any money and they may not have everything they need to support their families. But in actual fact, if they have a fag, it might actually support their family. So I think there's a big issue around taxation, and I think some of the money could be easily spent by communicating with individual people about how we can all work together to stop this. Thank you.
A very important point there, Councillor Shaw. Something around 60 to 70% of severely mentally ill people smoke. We're talking about schizophrenia, manic depression, etc. And something around 30 to 35% of the lesser mentally ill smoke. So in comparison to the 14 or 13.9% of national smoking, you can see it's an enormous challenge, and again, that's an area, again, like the prison community was, like other institutions, etc., and other areas like smoking and pregnancy, a huge priority, purely down to the fact that it's the percentage of people who are still actually smoking. So I think a point well made, Councillor Shaw. I'm going to use that to move on from the Chair's report. I thought I put 25 items on it and it would be quite a short report. Bryony, 12 items next time. Thank you very much indeed. We're going to move on to item number 8, which is integration and innovation working together to improve health and social care for all. Nobody can have escaped the fact that we're in an enormous position of transition. We're at the starting block for what I think will probably be some of the greatest changes that occur in NHS and social care in any of our lifetime. I'm incredibly excited about it. I think the work and the achievement that is going to occur in each and every one of our lives cannot be understated. For the first time, we're going to see health, social care, place-based work, housing, economy, schools, and everything through a single lens. And in order to tell us about that from Nottinghamshire CCG, we've got Lucy Dadge. Over to you, Lucy.
Thank you, and thank you for setting a very upbeat tone to this, because I agree. I think it is a fabulous opportunity. So Sue is going to support me. I'm just going to give you an overview of the paper, if that's okay. So we're here to present a paper on the implications of the Health and Social Care Act 2022 in relation to the work of the Nottinghamshire Health and Wellbeing Board and also the wider public services system. So it is actually quite quick. It's a little short of a year since the Integration and Innovation White Paper. That was July 2021. And I do think we are at the dawning of quite a seminal moment in terms of our health and care reforms. So the paper we provided outlines our new arrangements for planning and delivering health and care services, which, as Councillor Doddy says, formally commence on the 1st of July this year, when the provisions of the Act come into force. I think it's fair to say that rarely does legislative change in itself trigger major reform of public service delivery, but we are hopeful that the new architecture, together with our operating environment, gives us the right conditions for success in making really positive improvements to the health and wellbeing of our local populations in the way you've just discussed. And just to confirm, I think the main drivers that underpin the need for this reform to be successful mean that we've got to absolutely have to find new ways of working to reverse the growing disparity in health and wellbeing outcomes between our most well-engaged and our most excluded population groups. The Act asks us to build on the learning from COVID about what can actually be achieved when we all, as public sector partners, put a single focus on our most important issues, both as statutory partners coming together, but also building on the power of community activation. And also we must provide the right type of care and support in the right places at the right time to support our growing and ageing population. So the paper talks about the background and architecture for these reforms, but we do think this is a real opportunity for sustained improvements in the way we work together to improve not just the health but the life prospects of the people we serve. And just finally on the introduction, a core purpose of the Act is to establish a legislative framework that supports, this is longer term, sustainable collaboration between commissioners and providers of services across all sectors, so not just health and social care, and to move away from short-term competition for scarce human and financial resources. So briefly, just to take you through the architecture, nationally, and regionally, the oversight of health systems remains as it was, with NHSE overseeing our finance and quality performance, but regulating us as a system, moving away from regulating individual health and health providers and commissioners. And the CQC will have a real focus on reviewing and regulating quality of services provided, and they will rate our ICS as a whole. So you'll be used to ratings of hospitals. The ICS will have a rating from the CQC. Locally, what the Act does is introduces what we call a two-part statutory integrated care system. From a strategy and planning perspective, and please forgive all the acronyms, the ICB, the Integrated Care Board, is a new body that will continue, as CCGs have, to allocate NHS budgets and plan and commission services. But we will work very closely with local authority strategic commissioners to provide the best overall care to our populations. The ICB will be overseen by a unitary board, also called the Integrated Care Board, which won't be a membership organisation like CCGs were. And it has prescribed membership, so as well as NHS executives and non-executive directors, we'll have partner members from NHS providers. We'll also have a member with a dedicated focus on ensuring that mental health services have paritative esteem. There will be a general practice voice and an executive lead who focuses on children's services. And that's a recent change to the legislation. So the Integrated Care Board will inherit the statutory duties of CCGs, but it will also require new responsibilities. And some of these are quite technical, but I think some of these will be of interest to the Health and Wellbeing Board. So we will locally commission services previously commissioned by NHSE, like dentistry, optometry, screening, immunisation and vaccinations. So the ICB's main duty will be to create a joint forward plan for delivery of NHS mandated services, but that must take due account of the health and wellbeing strategy. So we have the Integrated Care Partnership, the ICP, which is the other part of the statutory ICS, and this will bring together a wider set of system partners to develop plans to address the broader health, public health and social care needs of the population. It will be a joint committee of the Integrated Care Board and the 2 local authorities, and the ICP will very much complement the work of the Health and Wellbeing Board and produce an integrated care partnership strategy, which will be founded on evidence produced through the JSNA, our population health management approaches, and very much citizen insights. And the ICB joint forward plan must give due regard to the integrated care partnership strategy, so you can see how these all work together. So in my view, the Health and Wellbeing Board becomes the fulcrum for all of our strategy development, and it will be an invaluable forum for ensuring that our joint work in the Integrated Care Board, the Integrated Care Partnership, and more widely works together in tandem rather than parallel to address our common aims, which we've talked about today, so which are improving outcomes for our citizens, improving provision of care through more integrated ways of working, promoting equity, which I think, as the Chair has said, is different to equality. We promote equity to drive out inequity in outcomes, experience and access to care. And we also have a duty to enhance productivity and value for money from our public services, and to encourage our citizens and communities to become active in managing their own care and retain their own independence. So I think that by optimising the interdependencies between the NHS Joint Forward Plan, the Integrated Care Partnership Strategy and the Health and Wellbeing Strategy, the NHS should also help support broader social and economic development beyond its core health mandate. So we have, that's the planning, that's the sort of the strategic planning of services. We've then got delivery of services in new and innovative ways, which are intended to break down the barriers between NHS bodies and other health and care provider organisations. And we need to stimulate effective ways of joined-up working. Statutory NHS providers will be mandated to work together at scale, so you'll hear about provider collaboratives. But as well as the provider collaboratives at scale, we must ensure that we generate and sustain a plural and diverse local supply of different providers with the skills and knowledge base to deliver the highest quality services, but also demonstrate wider social value outcomes. So we will have our collaboratives, our statutory providers, but we'll also very fundamentally have our place-based partnerships, which again the Chair has mentioned, and these will bring together our statutory and voluntary organisations to serve very local populations, providing services in a way that addresses our key priorities at county level, but using place-sensitive delivery models. And as you know, there will be 4 place-based partnerships serving the ICS and 3 of those in the county. And they will ensure community-facing integrated services tailored to population needs. And we can't, when we talk about the provider environment, we can't forget about primary care networks, which, as you know, consist of general practices working together with a range of local providers across primary care, community, social care, the voluntary sector, to offer a more personalised and coordinated health and social care service to local populations. Primary care networks will typically focus on populations, so these will be neighbourhood level of 30 to 50,000. And they should be small enough to maintain the traditional strengths of general practice, but at the same time large enough to provide resilience and support the development of integrated ways of working. So we hope that we will see collaborations of statutory providers, place-based partnerships and PCNs working together to deliver the health and wellbeing initiatives, and that we will dial up our community-based early intervention, preventative programmes, so that we really can start to shift the emphasis to preventing and avoiding illness wherever possible. And we've talked about lung disease, heart disease, diabetes. We can prevent it if that is our focus, and we need to focus our resources on preventing it and away from the very resource-intensive and less effective treatment and cure of disease burden. So I think, finally, for me, really, the most important thing, and I know that Cathy McLean, who will chair the Integrated Care Board, always says the most important thing when we think about the new architecture is to envisage the inverted pyramid with the neighbourhoods and the population at the top, served by the PCNs and the broader local services. And this is where we hope that most care provision will take place. The broader provider collaboratives will sit below that, and they will provide specific episodic care where and when it's needed, wrapped around citizens in a way that suits them. And the Integrated Care Board will be a very thin layer that sits at the bottom that facilitates these ways of working really closely with commissioners in local authorities to strategically plan and allocate our resources. And we need, and I think as Dawn said, we need to make sure that we're planning and allocating our resources according to need and positive impact on outcomes. Easy to say, hard to do, but we have to jointly commit to do that. And I think the Integrated Care Partnership and the Health and Wellbeing Board do set the context for the care that we need to provide. The paper describes, lastly, that the Integrated Care Board will be required to report annually on how it's performed in discharge of its functions, including the Health and Wellbeing Strategy, and there will be structured opportunities for the Health and Wellbeing Board to influence the work of the Integrated Care Board, who will also be consulted as part of an annual performance assessment by NHS England. Thank you.
Thank you, Lucy, managing to fit in probably description of the entirety of the new health and social care system in just a few minutes. And I think it's one of those things that you wish for when you are new to a body such as the Health and Wellbeing Board, Councillor Carlton, and then you hear it and you think, how am I ever going to understand any of this that's going on? And it is an enormously tricky thing in terms of letters when you hear of ICP and ICB, place-based partnerships, PCNs, primary care networks, and you think, well, I don't even know what they are, never mind what they do. So I think we'll come back time and time again, Lucy, to explaining the picture as such. Myself and Jeremy are somewhat spoiled in that we both work as GPs at the front line day in, day out, so we know primary care networks because we're part of them. We saw them emerge, we saw the change that was occurring, and we also have the benefit of being here and understanding the role of the Integrated Care Partnership, which again Cathy would describe as the guiding mind. So we as a Health and Wellbeing Board come up with a strategy. That strategy is based on the joint strategic needs assessments that are carried out within County Hall and City Hall. They identify the challenges of the community. That comes into a strategy which is, again, statutory. The Health and Wellbeing Boards have lost none of the statutory power that exists. They will continue to meet as we do now, and Nottinghamshire is one of the most frequent meeters that exists in the country. We meet more than other people. We have workshops. The next workshop will be on that exciting subject, smoking. In a month or so's time, and everything we do and everything we create will be fed through to the Integrated Care Partnership, who then influence the Integrated Care Board on how it spends the money that has traditionally been spent in hospitals and in secondary care. And Lucy makes a wonderful point that the most expensive system that exists in the world is the system that responds to things that have already happened, responding to the person who's had the heart attack, responding to the diabetic. And I know I did a short study in the surgery and looked at the number of people who were not diabetic before COVID and the number that were and had gone through pre-diabetes. And normally something like 10 or 14% of them might have gone on to be diabetic. And we were having 70 or 80% of them have become diabetic over that period because of change of diet and inactivity, etc. So these things are entirely preventable and I think will be part of our focus, it's lovely to hear secondary care talk about social and economic targets, because that's what we've been talking about for years, how to influence society, how to influence housing, school, the environments in which we're in order to improve the health and well-being of the people of Nottinghamshire. And I think that's our big challenge. The Health and Wellbeing Board it remains the driving force for the people of Nottinghamshire to influence the integrated care partnership, to actually put the resources into the community where each and every one of you represent the people that you go back to. The difference should be in the changes in place, and that's what we'll notice that you've never seen before. It may have happened on an ad hoc basis, but that was by accident. Now you're going to see those changes occur by design, and that's one of the most important things to take away. It's going to happen by design. Thank you again for that, Lucy, an enormous area to cover. Councillor Wilmot, are you scratching your head or did you want to say something?
Just like an observation.
That's fine.
Yeah, it's just an observation and at the end a question. But first of all, the music is ringing in my ears because you've said about the intervention schemes. For 30 odd years I've been going on about it, and many people have spoken about it on a number of occasions, but that's as far as it ever gets, as you well know. I mean, intervention is far better than having to treat the problem.
Yes.
I mean, stopping the problem before it begins it must be the number one priority. It's got to be. And it saves so much money. It will do in the end if we get it right. Yes. Can I also say that it seems that this new board is going to have a lot more teeth in it.
Yes.
So I hope that the services that it will be delivering, the health services that it will be delivering, will be much more successful because of that situation. Can I say also the first page of this document really opens up the eyes to the serious problems that this board will have in addressing the many problems. I mean, as it says in tackling the health and social care areas of concern for the people of our lovely area of Nottingham and Nottinghamshire. As it says in the report, reducing health inequalities, life expectancy is reducing, and the number of years people can expect to live in good health is also reducing, which in my lifetime has never happened. It's always gone up, but it is now decreasing, so that we're not getting it right. We can't be getting it right totally on that situation. And I say it also said the board will be following the new health and care bill that has received royal assent. I look forward to improvements with that. Obviously, a lot of people have been progressing with this report, and there must be lots of new ideas, hopefully, that will help our people out there, because they do need a lot of help. As it says in the report, the Health and Wellbeing Board was set with 5 strategic objectives and to deliver, and 4 main duties to perform. Some of them are very, what should we say, difficult, but you know, I'm sure we're all up for it to try and help in any way we possibly can. And as I say, working with the City Council and everyone else, it's we have to remember that in partnerships, very often it's difficult to work totally within partnerships because there's so many organisations and they do go different ways of performing, and they actually go different ways as well very often, and that's got to be continually looked at to make sure that everybody's on the same hymn sheet. Can I also say the report goes on to tell us what the board will have to follow. And all I can say is I'll look forward to see how this new system works. And can anyone tell me what is happening to the clinical commissioning group? because it seems that they have been left out of the system.
Thank you, Councillor Wilmot. Not only have the clinical commissioning groups not been left out, but you're beside the most important person in the clinical commissioning groups, Luti Daj. The clinical commissioning groups are the ICB. They have become the ICB, and they have amalgamated. All 7 of them have become one agency known as the Integrated Care Board. So, and therefore they will be able to disperse changes, etc., on a much more efficient basis over that single board, which is a very dynamic board of only about 15 people on it, representing all of the major providers from Nottinghamshire Healthcare to the Queen's Medical Centre to Kingsmill Hospital, etc. So it's going to be a very dynamic, very responsive, very active board with their first meeting on the 1st of July. That's how well ahead of it is. So CCGs, as you quite rightly say, I could have said it in one word, I said no, they've become the Integrated Care Board. They've not disappeared. You're absolutely right when you say for the first time in living memory, 100 years, the life expectancy of the population has actually started to fall rather than increase. They reckon that trend started before COVID, and that although COVID did have a number of excess deaths, etc., on it, that the trend had actually started before then. And some people think that there may be a significant relationship between the increase in obesity in population and ill health as a result of that. And therefore that's a trend which many people see to expect in the statistics that are going to be released in the next year or two. That is not necessarily going to reverse itself as COVID disappears. So that will be a real challenge for us going forward. Thank you very much indeed, Councillor Wilmot. Councillor Shaw.
Yeah, thank you, Chair. I just wanted to highlight point 10, which is close to my heart, obviously, from Basset Law, and that Basset Law has been introduced into the Nottinghamshire and Nottingham ICS boundary. I think that's a really important paragraph within this report to highlight. The inclusion of Basset Law into the ICS boundary will deliver stronger connections. And I'm sure it will. I'm looking forward to that. Our place-based partnership work to get to the point of 1st of July has been strong and innovative. And I welcome the work that Basset Law have done facing South Yorkshire and Basset Law, and now coming into Nottinghamshire is going to be an interesting addition, as I'm sure you think. And I think the work that Basset Law have done is innovative, and it'll be interesting to mesh that into the work taking place. It's an exciting time. Thank you.
Thank you, Councillor Shaw. Again, all of the concerns and worries that existed pre-integration of Basset Law into the ICS were unfounded, in that there will be no change in the person's day-to-day activity, the hospital provisions, the services provisions, any of that. And of course the County Council had been providing services to Basset Law anyway, so it was one contiguous border, and it made absolute sense to include it in the ICS. And we're working and looking forward to working with Basset Law as one of the 3 place-based partnerships with Mid-Nuts and South-Nuts. I think it's just going to be just as exciting for Basset Law going forward and for the population of Basset Law. Councillor, that's it, Brennan.
Thank you, Chairman. Thank you, Lucy. That was a really helpful overview of this paper, which is also excellent. I certainly fall into the category of people for whom understanding how all of these acronyms fit together has eluded me in the 2 years, I think, that I've been sitting here, and now it's just about I understand it, and we're now changing it all again. So that we'll see how that goes. This sounds more simple though, so that should suit me. On paragraph 12, it talks about performance assessment of the Integrated Care Board, and it talks about the relationship with the Health and Wellbeing Board with regard to that evaluation. I think, will the performance assessment be something that's regularly reported back to us? How do we know that these changes, yet more changes to the NHS infrastructure, are actually going to make some real change, real difference on the ground that we can touch, we can kick the tyres of to some extent? And so it would be really helpful to understand if and when you would expect to start seeing some positive outcomes that we could consider as part of our evaluation and as part of our engagement with the new structures.
Yes, so I think in common with quite a number of aspects of the bill, I think the mechanisms are here, and it's so there are certain things that we have to bring before you, but I think how we focus those is I think for us to develop in partnership with you. So our first, so you probably know that the Integrated Care Partnership has to produce its first strategy, get this right, by December this year, by the end of this calendar year. So I think, and that will be very much, I'm sure that will read across to the Health and Wellbeing Board strategy. So the Integrated Care Board has to produce its joint forward plan by end of March. So it will follow, so we've got the Health and Wellbeing strategy, the Integrated Care Partnership strategy, the Integrated Care Board, which will be the health response. So I think we will statutorily consult you as we develop that. So I think it's going to be, this year it's going to be quite a condensed, so the ICP doesn't sit till September. They've got to get their first strategy done by the end of December, and then the ICB. So it'd be quite a condensed timescale, but I think there's whatever opportunity as a board that you require to see as we develop our first strategies. I think my fundamental comment would be, and you know, Dr. Dave Briggs will be representing the ICB formally on this board, is that we have got an outcomes framework, and what we've done in the NHS a lot, and we will have to continue to do, is manage constitutional targets that are quite numerical. They don't go away, but what we can hold ourselves to account for here is what outcomes do they, how do they deliver better outcomes for our population? So I think probably a focus would be on our outcomes framework and achievement of outcomes.
Thank you. Yes, I think that would be really helpful, Chairman, if we can have a point in the process by which we receive the information regarding those outcomes, so that we've got something against which we can assess whether the changes are making any difference on the ground.
100%. I think it'll give an idea as to monitoring and evaluation processes in item 10, which we're looking specifically at how the health and wellbeing strategy will report back to the Health and Wellbeing Board, as I said previously, on system, place-based and priority agendas yearly, twice yearly and quarterly, and the Integrated Care Board is the more advanced at the moment, meeting on the 1st of July. The ICP is meeting in the 1st of September in a formed basis, with reports being produced by, as Lucy said, December. And you've got to remember that the Integrated Care Partnership is the combination of Nottingham and Nottinghamshire. So we won't just have the health and wellbeing strategy for Nottinghamshire, we will have the health and wellbeing strategy for Nottingham as well, combining to influence the ICP, to influence the ICB. So this will be a Nottingham and Nottinghamshire ICP, not just us, as we move forward. It's going to be moving at speed, and I think over a number of months the reports back will be quite substantial. I'm going to ask Councillor Tideswell.
Thank you, Chair. I've been listening to the arguments and this new partnership that we're going into with the health service. I know Councillor Wilmot was saying how much he's in favour of. I am certainly in favour of the reintroduction of health service working alongside social services. We all know that social health is as important as national health, your own personal health. And I remember the days when the health service used to work alongside what used to be Sure Start and is now Children's Early Learning Centre. Councillor Wilmot was highlighting the problem with lack of toilet training. Hopefully, if the health service are joining in partnership, we can start addressing that again. So yes, I am well looking forward to. We've been highlighting obesity and the problems with that. We've looked at the sugar, the tax and everything else. But the other aspect of obesity, one of the main causative effects of obesity is actually comfort eating. Nobody has mentioned that. We need to start looking outside the health and wellbeing box and make sure we cover all aspects so as we can have a positive outcome for especially the people in deprived areas. We all now well know the problem that centres like early learning centres are facing. And we were talking about bringing people on board to the health and wellbeing. I would like to propose that we actually look at inviting somebody from the Children's Early Learning Centre to be part of. I do believe it would be a very positive move. Thank you, Chair.
Thank you, Councillor Tideswell, and I remember the Sure Start Centre as well, and they've been replaced, as you said, with children's centres. And for me, it's the variety of services that exist within these places that is the key to their success, rather than what they're actually called in that sense. Obesity, we are up for an award for our Childhood Obesity Trailblazing project, which I remember being part of back in 2017 when we set out to find the holy grail, that is the intervention in childhood that would reduce the number of people turning up at school in the first year at age 5 being overweight, which was around 7 or 8% at that time. And it was to unlock what is it that we can do with these families to intervene to actually stop that original obesity, which then doubles when you're 12 or 14 to 15+%, and the recent statistics say it could be as high as 20%. I think that is something that the County Council have been hugely on the front line with, and that includes the children's centres providing education around nutritional food, giving out vouchers for people, involving families such as the parents learn how to cook healthy meals, etc. And it's been an exceptionally proactive service over the last 3 years, which is currently up for a national award. So we continue to search for that silver bullet, but it isn't a single item. And it isn't a single bullet, and it isn't a single grail. It's actually a combination of the usage of the multiple providing services that already exist within Nottinghamshire as a unity to feed into the various levels, particularly in families with children under 5, in order to reduce obesity before they ever get to school. So it's a huge area for Nottingham County Council, and one in which I say we've been enormously successful. And that's the national opinion on that.
Thank you, Chair.
David.
Could I just a real quick question? I know you mentioned dentistry, but how will that fit into the big picture? Will it be integrated care partnership where it says here other partners? How does that going to fit in? Just an overview, please.
Sorry, yes. So just very briefly, traditionally dental, optometry and pharmacy services are commissioned regionally, so on an East Midlands level on our behalf. So as clinical commissioning groups, we don't commission those services. There's a real recognition that if integrated care systems are going to become something real that manages the health of their populations, you've got to have dental, pharmacy and optometry. So by the end of this year, the local system, the Integrated Care Board, will be responsible for commissioning dental services, for example. And we recognise that it's a dental public health and backlogs are a huge issue post-COVID. So we will have that accountability from 2023.
Excellent, thank you.
Thank you, Lucy. Obviously prompted by the fact that there's been huge publicity around the inability, particularly over COVID, for people to get dental services, to the fact that they're resorting to pulling their own teeth out, and children's dental caries have risen enormously, and that's perhaps tied in with the national question as to whether we should have fluoridation in water, etc. But a lot of the dental problems have defaulted to general practice in A&E departments over that period of time, such that if you can't get into a dentist and you turn up in a GP surgery, we end up as dentists, although we're not actually trained to work as maxillofacial dental specialists. So there has been a default. One of the very positive things that's come out from the last scrutiny, when I was in health scrutiny looking at dental services, has been the 111 service, where they have a specific triager of dental problems that exists within that service, and also there's a 24-hour dental emergency number. So if somebody rings up and says, I need to see a dentist, well, we can't necessarily put them in with a local dentist, but there's an emergency dental number. But there's a huge amount of work which Lucy will be getting underway in terms of dental services in the very near future. Hold on to your teeth. I'm going to go first to Councillor Griffiths.
I'm a councillor now.
Sorry.
Just for promotion. I feel honoured to be amongst colleagues.
For Rushcliffe.
So, thank you ever so much, Lucy. I welcome this. I think it's long overdue. I think that we've had partnership boards for a long time, but they've not necessarily held each other to account in the way that I think that they needed to. I guess one of my concerns is that I absolutely echo and hear. I mean, I work on it from a day-to-day basis. I see the importance of prevention. I guess my concern is that we acknowledge that overall health and well-being is impacted by about 20% of it is impacted by our services. Other things, socioeconomic circumstances, education, air quality, that sort of thing. And yet a lot of the things that we wish to achieve here around improving our outcomes in population health and healthcare and improving experience and access will require more of our services. Now, our services are under huge pressures at this moment in terms of recovery. I know I did a clinic on Monday when I was on call for 11 hours and I dealt with about 50 to 60 people. That's an awful lot of people to try and to deal with day-to-day problems, never mind trying to deal with the prevention aspect of the agenda. And I guess what I hope for in going forwards is that we have partnerships that are transparent with their accountability to each other in terms of what they're going to deliver in the frameworks going forwards. A culture that's empathetic, because unless you actually understand the pressures that are out there, the waiting lists that exist for outpatients appointments, elective care, emergency care, diagnostics, and you expect more to be done by that system, you will not get engagement unless you actually approach that with a degree of sensitivity. So I will undoubtedly support the overall aims of this, but I think you do need to make sure that you understand what's out there at this moment in time. Or the Integrated Care Board needs to understand. It needs to be a really empathetic board to be successful.
Thank you, Jeremy. Indeed, under enormous strain. Did you say 40 to 60?
60.
60, right. It's a long time since I've seen 60 people. That's an incredible day's work. I'm just going to go to one more person, and then we really must move on to the Joint Strategic Needs Assessments, which are the ground for which we build strategies. I'm going to go on to Councillor Carson, and then move on from there.
Thank you, Chairman, and firstly, thank you for your warm welcome to this board here today for the first time. It's nice to meet you all, and I look forward to working with you all. Just to follow on from the comments from Jeremy, I thought that was sort of an eloquent point. Obviously, this is a very unique opportunity for us all collectively, not just in our county, but across the country. But I'm just going to turn it slightly to the social care part, obviously with my position in the administration here at Notts County Council, been the Deputy Cabinet Member for Adult Social Care and Public Health, that actually equally have also got that unique opportunity to put health and social care on a sort of a parity of esteem. You know, I'll share a little story. When I was first elected to this authority, then asked to become the Vice Chair, as it was as the committee then, you know, what was your understanding of social care? That really wasn't there until you needed it. But equally, that was partly wrong and blinded. So my own personal experiences was two. One was when my grandparents ended up in a care home setting, and the second one was from many years ago, growing up watching the BBC comedy programme called Waiting for God. So you probably had a little bit of a false understanding, knowledge of what actual social care is. And it's not just about that sort of care home, nursing home provision. It's actually so much more. And actually over the course of this last year on my journey in this authority, working with people like Sue and her team, for an example, actually it's a lot more to that. So obviously some of the challenges are quite well documented from a social care point of view, particularly in staff retention, and probably, you know, I'm a big believer, and again, Sue will back me up on this. Every time we have our briefing meetings, I'm always going on about learning from COVID period, and probably the social care issue has been a long-standing issue in this country under successive governments of different political colours. But obviously we have arrived at that critical moment. The last 2 years, whilst being a deeply sorrowful and painful time for some in our communities, is also probably collectively refocused our minds. And actually we can no longer work in silos. When we went into that lockdown period, how many groups and community bodies did come together to provide services and help our residents here in Nottinghamshire? You know, I'm under no illusions to that I alluded to of the challenges, but the opportunities are there, and certainly when there is a collective will and responsibility, I think we can make this work, but equally there has to be that accountability in there so we can actually keep driving it forward as well. Thank you.
Thank you, Councillor Carlton. With one of the biggest jobs at County Hall, adult social care, biggest budget, and nothing works if social care doesn't work. Lucy will be aware that around the hospitals in Nottingham, there are literally hundreds of people who are in beds waiting to be discharged. Now, social care and the NHS have had special agreements for a number of years to work across boundaries through Section 75 orders and the Better Care Fund, etc., allowing NHS money and social care to be shared in order to increase discharges and discharge to assess, etc. But nothing works if social care doesn't work, and the breadth and the depth of the portfolio that you look after is quite astounding. And as you said, for a lot of people, it's about care homes, and it's about an enormous amount of things, a huge amount of things. Sue, did you want to add anything to that?
Yeah, I think I might hopefully just give a couple of examples that will show the added value of the integrated care board that can bring to the work, and just some examples of the difference that ways of working can make. So we aligned our social care workforce around the primary care network and place-based boundaries, and we were already doing some of that before even ICSs were around. But what the programme that we're developing now, it links into what's already been said. We had bits of really good multidisciplinary working, but it's not consistent. So there's a real opportunity to how do health and social care work together, but with local communities, with the voluntary sector, so that people are having those preventative services before they come to their GP, before they start getting unwell. At the moment, people are passed from one to the other, and people fall through the gaps sometimes for that. So one example is some of the multidisciplinary teams are trying huddles. They get together, they discuss people, voluntary sector are there, other partners are there, and they work out who's best. So they're looking at everything all at once, rather than people being passed from one person to another. So it sounds really simple, but it is really helpful. They're having days where they're going out and reaching out and going out into the community, meeting local community leaders, finding out not only what's there, but people in those communities who might want to fill a gap in services as well. And then so the programme will enable us to work out what works well, and if it works out well, we should be doing that in all our community teams. And then where do we need to nuance it to make that to meet that local need? So some teams will be focused, some areas will want to focus on obesity, etc. more. So they will be working out how can they be more proactive in identifying people and what are the things they'll do. And also we've got 3 acute hospital systems across the county. We've done a lot of work to look at what we need to put in place, more integrated services to support people home. So as part of the ICS-ICB work, we're looking now at a business case for the funding. We know we like the home first principle. We know that we've got people going into beds that could have gone home. So we're looking at the business case and how can money shift from some of those services to fund the community services. So I think there's a lot more collaboration. It's been simplified by the services not being quite so fragmented as well. So those are just some of the examples that we're working on and how it will impact on local people in Nottinghamshire. I hope that's helpful.
Thank you, Sue. No doubt we'll be coming back for further examples exhaustively over the next number of months and years. Thank you very much for that. I'm going to move on to them because time is marching on, and I'm going to move on to. Do we have to do you have to move that, Pete, or do we have to do anything with it?
It's just for noting, Chair.
Just for noting. Thanks, Pete. So we're going to go on to item number 9, which is the Joint Strategic Needs Assessment Work Programme. Needless to say, the Joint Strategic Needs Assessment are a statutory obligation of the Health and Wellbeing Board, and you may say that we were set up in order to do this work. The first one, I believe, was produced in 2007, so we've got 15 years of joint strategic needs assessments. I think we've got about 44 live at the moment on Insight into the Health and to the Joint Strategic Needs Assessment website, and this is a constantly evolving tomb of work, and these things take months and months and months to produce. Now, I'm going to pass over to Dawn. Who am I passing over to? No, I'm passing over to, look at Sue. Where are you? Is it Sue? No, there's Sue and Lucy. So who's going to tell us about the Joint Strategic Needs Assessment Work Plan?
So, Councillor Duddy, it'll be myself, Lucy, and then passing over to Sue.
So we're just saying that the Joint Strategic Needs Assessment is the raison d'etre practically of the Health and Wellbeing Board, and is the basis of what we're going to provide information to the ICP with regards to developing the guiding mind going forward, that these are not simple things that are drawn up overnight. They take months and months and months of investigation, are particularly bespoke to exactly what Councillor Creamer was asking for earlier on, to pockets within Nottinghamshire, not Nottinghamshire itself. So without further ado, I'm going over to Lucy Hawkin. Carry on, Lucy.
Thank you very much. So yeah, I'm Lucy Hawkin, Public Health and Commissioning Manager working on the JSNA alongside Sue, who is our consultant lead for the JSNA. So the purpose of the paper today is to seek approval of the work programme for 22-23. and this was developed through our annual JSNA prioritisation process. So throughout that process, we received 9 formal submissions following our call out for suggestions earlier this year. And these were reviewed by both Public Health and CCG colleagues using our prioritisation matrix, which was shared with the board back in February. The process was overseen by our JSNA steering group. When we were reviewing the submissions, it was agreed that full JSNA chapters as they currently exist were not the most appropriate products for all topics. So we're proposing that some different products are produced depending on the required need, and we trial the effectiveness of a slightly more flexible approach to our JSNA this year. So our first proposed JSNA product is our Demography Chapter, and that's otherwise known as the People of Nottinghamshire. As well as producing a full JSNA chapter, we're proposing a summary of key points. And in terms of producing this, we are looking at a phased approach with the sections updated as data becomes available. And this is really because a lot of the data and information is coming from the census data, so we have to wait till that's released in the different phases. And then obviously if we wait until we have all of the data, there might be a delay in publishing the full chapter. So a phased approach seems the most sensible approach for this chapter. Moving on to substance misuse, a full JSNA chapter is proposed of this and should be ready for approval by the board later this year. Housing, because this is such a broad cross-cutting agenda with lots of work underway by various partners, initially we're conducting a scoping review, looking at where are the gaps in knowledge and where could a JSNA add the most value. And that's really to make sure we avoid duplication and ensure our resources are focused on producing something that could have the greatest impact. So work is underway on that scoping review. Following on from this, we've got health impacts of climate change for Nottinghamshire. So we're proposing a short, rapid review of this due to the fact it doesn't really align with our current JSNA template, and we're uncertain what data and information we can get locally at this point. So a good starting point would be to produce that short, rapid review. We've also then got diet and nutrition. So we're proposing what we're going to call a JSNA profile pack. So a trial of a new JSNA product with very similar content as our existing chapters, so falling under very similar headings, but in a shorter, more visual format. And then lastly, physical activity. The proposed plan is to update our Nottinghamshire Insight theme page because we have quite a good local understanding and there's some great work that's happened locally. So we're thinking at the moment the most useful approach for this topic would be to collate and update that information on that theme page. So that's a very quick summary of our proposed work plan for this year. I will now pass over to Sue, who's going to cover a few pieces of work which are very closely related to our JSNA work programme.
Great, thanks very much, Lucy. As been alluded to, for the JSNA, we're looking at a more flexible approach in terms of what would be more appropriate as a full chapter and what would be more appropriate as perhaps a profile or rapid review in that respect. So also, the system analytical unit of the ICS, it's quite a mouthful, but they've been doing some excellent work around their own data as well, particularly around dashboards, around what for the new ICS, what will it require in terms of data and looking at those wider determinants of prevention work as well, and also trying to link in the voluntary sector too. So with that wider recognition by the ICS of the need for looking at prevention and what we call wider determinants, a workshop was done on it's actually the 12th of May, just looking at these new innovations that are coming through in terms of JSNA, but also in terms of these other data sources. So it was quite a productive session, and we were looking at what what are the strengths and weaknesses, but also the opportunities. So a SWOT analysis of those new data sources coming through, particularly in relation to commissioning, and also the role of the JSNA in this as well. And then also, more importantly, how we can collaborate together to work to make sure the entire system, one, speaks to each other around data sources, people know where to access data, and also how to analyse it as well. So in terms of the workshop, these were the objectives and the purpose we were looking at. And then here are the key points that came through from the workshop, just showing that system-wide analytic vision is needed. And just to point out, yes, this was a joint workshop between Nottingham and Nottinghamshire, just to reflect that wider scope of the ICS. Key point around collaboration as well. We need to get that full analytic picture, including community validation. So has been alluded to, that really important aspect of lived experience and those case studies that we need to hear. We need to hear the voices of the community as well, not just data speaking to us. And also clarity of data source bases and hosting of these products. Where actually are they going to sit, and are you actually able to access them? And so it was as a productive workshop, as I said. The next step is meeting with the System Analytical Intelligence Unit and the Directors of Public Health to discuss findings from this workshop and perhaps develop an action plan. We're also meeting with the new Medical Director, who has the JSNA in his new portfolio. So that's quite an exciting development from that. And also the System Analytical Intelligence Unit, there is a strategic oversight group that has membership from data intelligence across the board, looking at how we can strategically make sure these data sources link to each other and give us the full picture. So that's just an update around what's happening with the JSNA and how it fits into population health and data sources, which I think is a really good development in terms of getting coherence across the data system, and also the importance of bringing in that lived experience and the voice of the community. And just to say a little bit about the COVID impact assessment, it's in the report there. It is looking at the impact of the COVID pandemic on health and wellbeing and inequalities. We've got 8 phases because, as you can imagine, there's an awful lot of data coming through, an awful lot of different impacts that have already been alluded to in this meeting. So we're bringing each of the different phases to one, the public health senior leadership team, just to give that public health feedback. Then it'll go to the appropriate programme board for each of these 8 subjects. And then it'll be brought to the Health and Wellbeing Board with recommendations that the board can feed back on. So rest assured that there is work going on around the initial impact of COVID. Obviously, we'll get more data and more information as the months and years go by, but this should bring in at least an initial assessment of the COVID impact on Nottinghamshire. So thank you very much. That's just our update on the JSNA work programme and a couple of pieces of work that are related. Thank you, Chair.
Thank you, Sue. Thank you, Lucy. I have to say that if ever I get charged with doing a piece of work or reporting on something, be it obesity, be it smoking, my first port of call is always to read the Joint Strategic Needs Assessment on the Nottinghamshire site, and the amount of information that exists in that is quite staggering, and it's a very useful tool. And I would say to anybody, if you're looking to see, if it's alcohol, if it's drug abuse, if it's childhood autism, if it's anything you want, start with the JSNAs, because they're a wonderful source of local information right down to borough level, etc. There's a lot of mention of Nottingham and Nottinghamshire. We both have our own separate public health departments, both producing our own statistics for our own populations. Is that correct, Sue?
Yes, it is. Sometimes we do joint JSNA chapters. That has happened in the past. So there are areas where it does make sense to work together, and so that absolutely happens. And of course, the workshop that we did here was really useful in aligning those two methods of producing the JSNA and the work with the ICS with their own data sources and dashboards. So yeah, there's close working, but they are two separate entities. Yeah.
Yes. Does information feed up or does it feed down? So when you look at sort of, things like the global burden of disease statistics and things like that, which have overviews of populations and interventions, and then you have you guys working from the bottom upwards, is there an interaction between the two? Does it normally come down? Does it come up? How does that sort of stuff interact?
At the moment, we do have both it feeding down nationally. In terms of COVID, there's a national dashboard that tells you what's happening around COVID impact at a national level that you can extrapolate a bit to local level, and there is the public health outcomes framework that does have the local information as well. But importantly, what we're trying to do, and it's especially important with these place-based partnerships, is to have that bottom-up information as well, particularly at a local level. So that's what we're working hard to enhance as well, particularly around, as I said, the lived experience, bringing that through as an important aspect. So the place-based partnerships are going to be really important in bringing that local knowledge and experience to the JSNA and also our data on population health as a whole.
Thank you, Sue. And of course, that the ICS may be new, the ICP may be new, place-based partnerships are not new, are maybe new, but joint strategic needs assessments are not new. We may be adapting them to the new world in which we find ourselves, but they're certainly not new. I'm going to go over to Dr. Jeremy Griffiths.
Thank you both. I'm sure that doing all this work as you do, the most important thing for you is that it has impact on making change. And I just want to go back a little bit to the thing you talked about the lived experience. From your perspective, what do you think will be an acceptable level of scale of this? Because obviously you can go into granularity on an individual person basis. Have you any thoughts about what will be seen as being valid from that perspective?
It can be difficult to gauge, but lived experience as individual narratives of experience can serve to highlight the fuller data we have on at a local level from a data perspective. So it can really bring stories to light that the data is actually telling us. But also collectively, from a lived experience perspective, if we're having stories coming through from a local level that perhaps tell a different story to what the data is saying, then that may be bringing in that local flavour, that nuances, particularly maybe around why children are wearing nappies to school at 5 years. The national data might be saying something, but actually from the lived experience and voices we're hearing, the reasons behind it may be actually nuanced to that particular area. So I agree, it is a bit of a balance, but it is important that we do have both.
And do you anticipate in the future in the JSNA that there may be a section that talks about themes from lived experience? So to actually recognise it within your reports?
I'd say we hope to. I think there's more scope for that given the work of the place-based partnerships and that local flavour coming through. I don't know whether Lucy's got any perspectives from her work as the whole JSNA, but I think that's certainly a probability as we go forward with the work that is going to go on. Anything from you, Lucy?
No, just to add, within the current template, we have the local voice section, which admittedly some chapters we have a lot stronger input into. For example, the Looked After Children chapter that we're producing at the moment, we're hoping to get the group involved in that. So definitely that feed through is a lot stronger in some areas than it is with others, but it's definitely an important part of the JSNA.
Okay, thank you.
Thank you. JSNAs is something that we're going to hear about at each and every single meeting going forward. We look forward to seeing the developments. I'm going to move that the purpose of the report is to seek approval, etc., for the work programme proposed. And Jeremy, have
Yes,
we got a seconder? Yes, all those in favour? Thank you. Thank you very much to Lucy and Sue. Thank you.
Thank you.
Thank you, guys.
I assume it's over and done. I just want to ask a very quick question.
You can ask a very quick question, Councillor.
And it's only one very quick comment as well. 4 and 7. It'd be very interesting to put those two together. So thank you for that. But on the COVID, when it says direct influence of COVID, is that direct influence of COVID stroke long COVID, or is it just COVID? That was just for clarification more than anything else.
Oh, I see. Yeah. So in terms of the scope of that, yeah, that's one we're still looking at, because obviously the direct impact is still going on, and unfortunately people are still dying from COVID, and there's still a vaccination campaign going on as well. So in terms of the scope of that is around people who have unfortunately passed away from COVID, the vaccination campaign, people who have long COVID or post-COVID syndrome, as it's called, and so that's the effect on inequalities around that, and also going to be a little bit about those who are clinically extremely vulnerable, because the COVID virus is still having an effect and an impact on them. But as I said, that's still a little bit of a work in progress, that one. But I hope that clarifies for you.
Thank you.
Thank you, Councillor Creamer. Again, I'm going to move on now, bearing in mind the time, to item number 10, which is the monitoring and evaluation of joint and health and wellbeing strategy. Throughout the afternoon, people have been hearing about things that are going to happen, but as Councillor Brennan, etc., brought up, it's how do we monitor and look at what the impact is of the interventions that we're carrying out from now and over the next 4 years, be they on the part of the ICB and the CCGs in Lucy Judge's area, the ICS, the County Council. How are we monitoring and evaluating this strategy in terms of that? So again, I think I've got Sue Foley down for this. Have we got Sue Foley?
Yes, haven't escaped. It's myself and Bryony doing a double act on this one. So Bryony's gonna take it away, and then I'll speak a bit later.
Carry on, Bryony.
Yep. Afternoon, everyone. I will keep it short and sweet, hopefully, bearing in mind the time. But what I'll start with is a very quick recap of what we've previously presented to board and have been developing sort of over the last year or so. So as you'll see within the board chamber, there are hard copies of the new health and wellbeing strategy that we're very pleased to say has been signed off and is ready to be implemented. And the presentation today will be about how we will be monitoring and evaluating that moving forward. Caveated that this is going to be a test and learn approach. So similar to discussions that sort of Lucy and others have presented, we're very much going to be evolving and embedding this as we move forward through delivery. But what you can see on this slide is just a very quick one-page summary of what we've agreed as part of the strategy. So there are 4 ambitions. The first being about giving every child the best chance of maximising the potential. The second about creating healthy and sustainable places, which as a board and a set of partners we've done lots of work in the past on, because this is a continuation of an ambition from our past strategy. Our third ambition is about accessing the right support to improve people's health. And our last ambition is about keeping our communities safe and healthy. And as you'll see, even though we do a lot of work that covers a lot of different spectrums, we've identified 9 priority areas, which has come out of an extensive period of engagement with residents, partners, and a workshop with board members as well. Moving on, again, I'll just very quickly recap the sort of architecture for delivery. bearing in mind that we have a short public version and then we have longer versions of the strategy for people and officers to use for delivery. But what we are currently developing is 4 action frameworks aligned to each of the ambitions that specify the evidence and the actions of how we're going to be successfully delivering this strategy. And alongside that, we'll be having 4 programme groups that will be responsible for that oversight, as well as reporting to the Health and Wellbeing Board. When we were looking at how we would monitor and evaluate, we posed a number of questions. We did set up a task and finish group, which Sue will speak to in a second, but it's very much about starting with what we want to achieve and then working backwards. So what benefits do we want to see? What changes do we want to successfully deliver? And therefore, what actions do we need to be taking, and how will we know that they're actually being successful in delivering what we want to do? And as you can see, that also involves the scale of the actions, having a structure in place to mitigate any risks or unforeseen consequences, also known as a ripple effect, to understand what impact, good and bad, will this strategy possibly be having, so we can take appropriate actions to modify it, and therefore ask ourselves, what do we need to change, if anything, according to what we're doing? And then again, how has this all helped us to achieve our vision and our ambitions over the next 4 years? And as I mentioned, this will mean that we'll probably have to test and adjust as we move through delivery. And what I'll do is I'll pass over to Sue to outline some of the thinking and summarise on a page what the actual monitoring and evaluation framework should look like.
Thanks, Bryony.
Go ahead, Sue.
Yeah, thank you. So there is, of course, a task and finish group that we established soon after the strategy was approved. It does have representation from public health, all of the place-based partnerships, and also the ICS. So making sure that we do have that buy-in from all the partners, and also we're trying to link in with the voluntary sector as well to make sure that they're represented in this endeavour too. So the group has proposed a framework, and there is the guidance document has been developed, and it will be part of that aid memoir as well. Now, admittedly, this page does look rather scary, but we will circulate the slides later on. It's just show this is the plan on a page, so hopefully this should, in one page, just be able to summarise what the monitoring and evaluation plan is all about. The main points to make just for this part is that it is multi-level, so we are going to look at the effect of the strategy as a whole, and the system as a whole. And if you could be able to see there, it will include looking at the ICS outcome framework and linking with that as one of the indicators we're going to look at. Then we are going to look at the strategy from the position of the 4 ambitions, the 9 priorities, and also the place-based partnerships as well, because they are one of the main delivery mechanisms that we're looking at for this strategy. We are looking at mixed methods approach. Of course, there will be some really pertinent indicators, and not very many of them, but there will be pertinent indicators that we're going to look at. But also there's going to be a toolkit looking for that richer evidence. As Bryony said, one of them is the ripple effect. How has your intervention had consequences beyond your initial intentions, good or bad? Particularly around test, learn and build, so making sure that we do allow innovation, we do allow ourselves to fail a little bit, and in order that we learn. So there will be a toolkit for that richer evidence coming through. Ooh. Okay, so a summary of what's going to come out to yourselves as a board for the monitoring and evaluation. From a system level, which is that strategic vision that we have, there will be an annual report that looks at is the strategy and the evidence behind it moving in the right direction that we want towards achieving that vision. So it will be an annual report, but also be looking at the integrated partnership working that's so important for making this a success as well. So those will be the 2 areas that that system annual report will cover. For the 4 ambitions, there will be a quarterly report required from each of the 4 ambitions. This will be a very short report, no more than 10 pages, and there will be a checklist of criteria that we'll expect to see in that report. And there'll also be expected an annual report from each of the ambitions detailing how progress has been made for the ambition as a whole over the year. But this will be where feedback from the board, yourselves as a board, will be really important as to is the reporting and the evidence being presented saying what, giving that indication and the right level of impact being made, and have you got enough evidence to show one way or another whether the strategy is being a success. So feedback from the board will really help with that test and adjust process that we're bringing in. In terms of the 9 priorities, they will be expected to feed into that quarterly report for each of the 4 ambitions, and there'll also be flexibility around ad hoc reporting as well. So priority lead for each of the priorities, or the board may request that an ad hoc report goes in just to enhance what the board knows, what the board can do around a particular priority. And also the board itself, you can request, if you're feeling you're not cited enough on a particular priority, you can request an ad hoc report from a priority as well. So hopefully we're bringing in that flexibility. And also, of course, there are workshops that can be requested from each of the priorities, or perhaps an ambition, to be able to bring in that rich development and face-to-face working for the board as well. So obviously the next one is going to be tobacco control in July, which will be the next one. So there is that option as well. So that's the main summary around monitoring and evaluation. I'll just get Brian to give a quick update around the website with a star turn from our chair, as you can see up there, and then we'll highlight what the next steps are for the monitoring and evaluation and what you can expect the board to see in the months to come. Thank you, Brian.
So you'll see that we have newly launched a website. So this is the first time the Health and Wellbeing Board itself has had a website, but actually its main purpose, is to be an interactive and engaging way for residents to find out about the strategy. Yes, we have hard copies, but actually what we're hoping to do is make this a really easy, accessible way for residents to find out what we as a group of partners are doing to improve people's health and wellbeing. This will also be one communication method where we'll be providing updates on progress. So people can go back to this website time and time again to find out what we're doing on tobacco or what we're doing to improve people's mental health, and to be a point of call both for support, because we will be also signposting to other websites and other services available, but also to have increased transparency in all the work that the board is doing. In terms of next steps, and I can see we have 1 minute on the clock, we'll be establishing the structures that we've just ran through, and we will be reporting back to board hopefully around December time, starting delivery during the summer.
Thank you, Brian. Sorry, could you go back a slide there? Who is that homeless man that's in that? Thanks very much indeed. I think the concept of multi-level mixed method is the phrase I'll take away with me there, quantitative and qualitative, and I think some things lend themselves to measurement in a quarterly basis. Others, like life expectancy, obviously can't be reported on that sort of level, but it's certainly very comprehensive. It's a build and learn process that when we know that what we're building works, we'll keep doing it, otherwise we'll do something different. So I'm going to go up to Sarah. Sarah, come in.
Just a real quick one, thank you, Chair. I just wonder if we could have those slides shared, as they weren't part of the pack. There was just one slide in the pack. It'd be really helpful if we could have that shared to members after the meeting.
Yes, absolutely, yeah.
Thank you.
Yeah.
I'm going to see if any... It's not Councillor Wilmot, is it? No. Carry on. Go. Yes. So carry on, Councillor Wilmot.
Thank you very much, Chair. Yeah, this joint health and wellbeing strategy needs to be a robust framework, and it looks to have it. I like the 5 guiding questions. But really, that they will find out if the strategy is to be a success, or whether it'll work or not. That will definitely come to the fore. I do like the idea of the system, strategic vision, ambitions and priorities put down on the paperwork. But on the priorities, you haven't got drug abuse and gambling addiction, which, believe it or not, are one of the worst things for people to get ill with when they have got those 2 problems. I just wondered why you haven't got that on the issue. As I say, everything else it looks really good, and as I say, it'll be no joyride. I can tell you that with all this, the necessary stuff that you put in, and these issues are serious, very, very serious, and need to be addressed. And we all need to get on with the case, really. Thank you.
Thank you very much indeed, Councillor Wilmot. And I think it's a journey we'll go on together, and I think it's going to be very exciting over the next number of years. Thank you, Sue. What I'm going to do is I'm going to formally move the recommendation. Jeremy just seconded, and just to say that we moved the recommendations on the agenda pack. All those in favour? Fantastic. We've got one more item that we're going to move on to, called the Works programme, and it's just going to look ahead at the work that we plan to do going forward. I'm just going to interrupt that before we do to say that this is possibly the last meeting of Dr. Jeremy Griffiths. I would have to say that Jeremy has been a part of this for longer than I've been a part of it. He's like the cornerstone of a house. It's almost like that we've built this with Jeremy there forever. His contributions are extraordinary. His insight has been extraordinary. I know I have come and gone as the chair. He has been there forever. I think, Brian, you calculated how many hours, minutes, days that Jeremy has been sat there.
Not quite, although it was a dark hole of various board papers, but he's been a member from the beginning, from its shadow form back in 2012. He became chair in January 2016, and give or take a few cancelled meetings and a few holidays, that equates to 72 board meetings over the last decade, which is quite a tremendous contribution.
And extraordinary. So we just want to thank Jeremy for that. Did you bring a cake or anything, Bryony? We're going to forget about obesity for today.
No cake.
No cake.
But a little gift.
A little gift. Yes.
Thank you.
Yes. Bryony, could we take a little picture of you presenting that? Would that be possible?
We can.
Could you?
YouTube might not want
to people on YouTube, this is going round the world. I mean, this could be bigger than anything TikTok, whatever it's called. Yes, I think one for the global audience would be useful. Brian, come back up here, and you can stand beside me, Jeremy. If you stand up there, and have we got a photographer? Let's have somebody to take a photograph.
There we go.
Dawn, I'm going to make you honorary photographer for today. This is the multimedia public health skills. If you don't stop laughing, I'm going to put you in the photograph, Councillor Wilmot. You can deputise for me. All right.
There we go.
Thanks very much. Now that wasn't in the work programme, but it could have been in the work programme.
Can I just say something?
Yes, let me call on Jeremy to say a few words.
Yeah, I just thank you very much for your acknowledgement. I'm not going to be on the ICB of the new organisation. I've obviously been representing the clinical commissioning groups, which are now being phased out. I'm wholeheartedly dedicated to prevention in what I do as a general practitioner. I'm going to carry on doing work on the tobacco side. I'm on the prevention board at Queen's. So I'm not going away. I'm just not going to be part of this committee, but I will keep an eye on things. And I do salute you all for what you do, because I know that all of you, by the very fact that you're sitting in this room, are dedicated to prevention and the care of our patients, your population. So thank you for all you keep doing. More energy to you. It's a huge challenge that's out there. But I'm sure with your collective intelligence and your motivation and drive, we can make a big difference collectively going forwards. So thank you for all you do as well. Thank you.
Jeremy will return. Maybe not next week or next month, but certainly over the next number of years. No question about that. So I'm going to just say on the work programme that we're going to have our requisite number of meetings, again, 22, 23, one of the hardest working health and wellbeing boards in the country, and looking at today an extraordinarily well represented board, and we will continue to be the guiding mind of the ICP and the ICB going forward, because it is right here with you people that we formulate the strategy that is going to drive the care of the population over the next 4 years. And like Jeremy, I'd like to thank you enormously for the work you do. And remember, next up, the smoking workshop, interactive. It's going to be better than Top Gun and Maverick. It's going to be out there. It's going to be out there. So it's a lovely evening. I think it's time to hit the pub gardens. Thank you very much indeed. Thank you.